Hello, and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Joyelle Ray Alexander, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we will be taking your questions throughout the hour by phone. The toll-free number is 800-452-0662, or you may send your written questions by fax. The fax number is 518-426-0696. We will also be taking questions by email. Please email us at any time throughout the hour at phlive.newyork@gmail.com. Today's program is Engaging and Activating Patients for Better Health, the Power of the Chronic Disease Self-Management Program. Our guest is Lisa Ferretti, a social worker and public service professor and co-director of the Center for Excellence in Aging and Community Wellness. Thank you very much for being here, Lisa.
Thank you, Joyelle. I am thrilled and honored to be here today. Thanks.
Well, this is an exciting topic, and we're going to get right into it. We're here to talk about the Chronic Disease Self-Management Program, but before we do that, I wonder if you could talk a little bit about what self-management is.
Sure. Self-management really focuses on the patient and what the patient believes is happening with their health care and their chronic condition. So it really focuses to help people to understand how to build confidence that they can better manage their chronic health condition. And so by recognizing the patient's central role, we really approach this differently. So rather than prescribing things for people necessarily, we focus on getting people to think about what's important to them and how they can make changes and how to make decisions about how to implement the changes that they want to make in their lives. And so it really builds people to develop proactive strategies and adaptive strategies so that they can manage the day-to-day management of their chronic health condition, whatever that may be. And it also employs kind of a team-based effort. So we really look at it as a holistic kind of team approach where we really want everyone who's part of the healthcare team. So it's not just the doctors and the nurses and the patient, but also family members, friends, co-workers, and the community that really support the person as they manage day-to-day their chronic health care.
A truly comprehensive effort.
Yeah, it definitely is.
Now, it sounds a little bit like patient health education. Why is self-management different from patient education?
Yeah, I think that the main difference between self-management education and patient health education is that self-management education really seeks to help people to build the skills that they need to make changes that they want to make in their lives related to their health. So patient education provides people with the knowledge that they need about their health condition. So, you need to learn about your disease and your disease process, what you can expect, what will happen, and that's really important. But you also need to know how to apply that knowledge in your life. So how are you going to, make the changes that you might want to make? Knowledge informs behavior change, but knowing something doesn't necessarily mean that you're going to do it, right? So,
Absolutely.
Let me give you an example. Many people know that getting more physical activity on a regular basis is something that can really help your health. Is that something that you're aware of?
You're absolutely right, but
sure.
Being aware of it and doing it, two different things.
That's right. So you know that, and sometimes you still probably don't do it. So why? Why don't you do things that you know are good for you?
Oh, I don't know, Lisa.
So probably for the same reasons many people don't, right?
Okay.
You don't have enough time, you've got too many things going on, maybe you're having pain that day, maybe there's other things happening in your life. So
Sure.
all these reasons that you don't achieve things that you know are really good for you. And so self-management education really seeks to give people the skills and the tools that they need to be able to do those things on a regular basis. So you know something that you learn from patient health education, and self-management education helps you to do it. So it's really about the application of that knowledge. These two things are really complementary, and we really can't do one well without the other. So, I think we really need to find ways to make those things work better together.
I agree. The chronic disease self-management program has been around for a while. Now, but there seems to be a lot of interest in the program recently. Next, we're going to hear from Philip McCallion, professor and co-director of the Center for Excellence in Aging and Community Wellness. He will set some context into the recent expansion of the chronic disease self-management program. So let's take a look.
Hi, I'm Philip McCallion. I'm with the Center for Excellence in Aging and Community Wellness. There are lots of good programs out there. One of the things that distinguishes CDSMP is that there has been this very concerted effort, supported by multiple agencies and multiple funders, to develop an infrastructure across the country. And certainly here in New York, there has been very significant investments by Centers for Disease Control, by the Administration on Aging, by the Department of Health, by the State Office for the Aging, and then on a more local level, by hospitals, by county offices for the aging, by faith communities. There's a whole variety of partners. But what all of that really means is that we're starting to see an infrastructure really being developed and really taking hold in communities, certainly across the state and across the country, that it becomes possible that, having been convinced that something like CDSMP might be very helpful for patients, that physicians and other health providers can say, you know what, I'm going to refer you to a class, and there will be a class that a person can be referred to. It's going to be happening within a time frame that makes sense, and it's likely to be happening in a place that the person can access. And that's what infrastructure really is about. It's building something so that when someone can benefit from a program, it's actually available to them to be able to participate in it. So it's a very important part of what CDSMP has to offer today, is that this infrastructure has been built and continues to be built. There's an awful lot going on in the healthcare environment at the moment. A lot of new initiatives, a lot of considerations around cost controls, a lot of considerations around better management of care, happening certainly within Medicaid and Medicare, but happening more generally as we look at the redesign of some of our healthcare system. Some of it clearly is being influenced as well by our considerations around the multiple chronic conditions framework, sort of really trying to understand, and I'll step back a little bit. One of the things that's very striking to me is that we talk about the size of the chronic disease, the population with chronic conditions and chronic diseases. And one of the factors in that is that for so many people, there's more than one chronic condition. And so we really are looking within the different reform efforts within healthcare at how do we grasp that? How do we redesign our systems to better support the whole person? And so we're seeing initiatives certainly like health homes, medical homes. We're seeing initiatives that again focus much more upon self-management and the linkage in with community supports and resources. CDSMP clearly offers an opportunity to be able to advance some of those things. Within one of the if you like, the stable of CDSMP programs, the Diabetes Self-Management Program, there's already efforts to look at making that particular program reimbursable under Medicare. There are explorations happening as to where this program fits within constellations of services. If not to be reimbursed specifically, can it be part of a package that can be reimbursed? I think, for example, under health homes, the ideas around that there be a self-management component of that, this becomes a program that potentially could be used to advance those kinds of ideas. And again, there's lots of other programs. There are programs that have evidence to support them as well. The attraction here is to think about that this is a program that's likely to have infrastructure. that's likely to be something that can be more universally available. And I think that we also have to think about this in terms of what's the potential to impact upon large numbers of people, whole communities potentially, as well as addressing individual needs. And I think that that's the promise that CDSMP offers in the midst of all of these reform efforts.
Well, that was some great information that Philip covered. There's obviously increased interest in self-management education and the chronic disease self-management program. Lisa, what do you think is behind this? What do you think is moving the interest?
Well, I think there's many things that are moving the interest. I'll maybe talk just about a few. First, the national data is really pretty compelling. When you consider that over the past 10 years, we have seen a steady increase of the numbers of people with chronic conditions, and we're projected by 2030 to have about 170 million Americans who are living with chronic conditions. So that's an increase of about 37%. So there's certainly, interest in how we're going to better manage this as we move forward, because we know we're going to have people living longer and with more chronic conditions. The second thing I think is that we also recognize that people with chronic conditions represent a lot of costs to the healthcare system, and so I don't want to, overplay the concerns everyone has about costs, but certainly healthcare costs are rising, and a lot of the healthcare costs that are rising are related to these chronic healthcare conditions. So it's not as much maybe the ongoing care, but more the acute events that can happen for people who really have long-term health conditions. And the more health conditions somebody has, the more likely they're going to have a hospital inpatient stay, and they're going to be in the hospital probably longer. So that's kind of moving interest as well, because there's a cost question about that. But beyond the cost piece, the fact that we have people living with multiple chronic conditions is also of great interest to everybody at this point, because we've got to figure a way to help manage this. I mean, our healthcare system was set up to manage acute care. So people get sick, they go to the doctors, they get better. Well, that's not what happens with a chronic healthcare condition. You get sick, you get better because you get some treatment for your condition, but you've got to figure out how to manage this now for the rest of your life. And there's a lot of work at the national level looking at how are we going to do this if we know that we're going to live longer and live longer with chronic conditions. So that's another thing that's moving the interest. And I think the third piece that's really important is what we've seen in really the advent of technology. Technology, particularly things like electronic health records and other types of interactions that we can now have with patients in an ongoing way, presents this opportunity, if you will, to figure out how we can really work with people in their self-care. Because if we think about it, really, care that we get from our physicians when we have a chronic healthcare conditions probably is about 5% of the time, out of the whole piece of this, right? 95% of the care that we do is self-care. It's what we do at home. It's the decisions we make about what we're going to eat and when we're going to exercise and how we're going to take our medications and all those things. And so technology represents an opportunity for us to influence that with people and really be more of a team, on a more day-to-day basis. So I think that all those things and many other things are moving that interest.
Okay, well, many other things, as you said. So maybe you could tell us in a bit more detail, if you will, Lisa, about the chronic disease self-management program. How was it developed, and how do we know that it works?
Okay, well, I'd be happy to tell you more about that. And actually, the first thing I'm going to tell you is that we don't call it the chronic disease self-management program. And that's largely because a lot of people actually living with chronic healthcare conditions don't actually identify with that language. So one of the very few things you can change about the program is the name. And so here in New York State, we actually call it the Living Healthy New York program, but it's known by many, many other names, in many places around the country and really around the world. What you need to know that's really important, I think, about the Chronic Disease Self-Management Program, or I might call it now the CDSMP for short, is that it's an evidence-based health promotion program. So it was developed with a randomized control trial, and through that randomized control trial, a number of participants were sort of, put into the intervention group and into the control group, or the group that didn't receive the program. And what we really saw were significant changes in self-management, in health status, in symptom management, and other things for the folks who took the program. So unlike many other programs, the CDSMP has this, large amount of evidence behind it. In addition to that, the Chronic Disease Self-Management Program actually addresses the concerns and the problems that are really common to people who have any type of health condition. So you don't necessarily, it's not just a class for people with diabetes, but people with diabetes are in the same class as people with arthritis, osteoporosis, heart disease, depression, etc. And because of that, you actually have these incredible interactions between the participants that really help people to support one another and to learn strategies from one another in a very encouraging and interactive environment. So it's a really dynamic program as well. So I think that that also attracts a lot of people to it. It's also a program that's really appropriate for caregivers. People who take care of other people oftentimes really are more focused on the person they're taking care of than on themselves, and they may very well have chronic health conditions of their own. So the program helps caregivers to see both how to better manage their own condition, but also how to deal with some of the problems that they might be having trying to help someone else who is also a self-manager, by the way, trying to make those decisions. And so I think it has a lot of dynamic pieces in terms of that as well. You know, it gives people an opportunity to really figure this stuff out, practice the skills, and learn how to apply them, and then get feedback from their peers as they sort of work through how they're going to manage their day-to-day management of their chronic health care.
Would a caregiver be at one of those sessions with their patient or independent of their patient, or a combination of both?
Yeah, actually it could be both. And you know, it's very dynamic when you have caregivers and the people they care for in the same workshop, because you know, a lot of light bulbs go off for people as you go through these things. You know, one of the things we see that's real interesting with caregivers is that oftentimes caregivers want to make goals that are really the goals of the people they're caring for. And so while sometimes we see some tension, there's also an opportunity to really bridge some of that and help everybody to have better interactions.
Now, Lisa, you touched upon the self-management techniques. How do they work?
Yeah, so self-management techniques, you know, are the things that we teach people in the workshop that help them to learn how to apply these things. So some of the things we do is we have people set short-term goals, like they make what we call a weekly action plan. And so they decide what they want to do, they implement the plan, knowing that they're going to come back the next week and talk with the participants in their workshop. So there's a little bit of accountability and so some gentle persuasion that happens. But it also is a way for people to taste success. So if they pick something that they're successful with, they get a lot of positive reinforcement from the group. If they're not successful, what they also get is they get an opportunity to help figure out why. So some of that problem solving, and so to develop those kinds of problem solving skills that will help them ongoing to manage outside of the workshop. We also have a lot of symptom management techniques that we see used, so cognitive symptom management or thinking type techniques that we use, like distraction, positive thinking, progressive muscle relaxation, those kinds of things. And other types of strategies that we use, we have like this whole self-management toolbox that teaches people multiple tools, but beyond just the multiple techniques or tools is that we teach people that most of those tools can be used to address many of the symptoms, whether they're physical symptoms or emotional symptoms or whatever. And that actually gives people sort of a real arsenal, you know, that they can kind of go after the problems that they're experiencing. And so it's really very powerful.
Powerful and very interesting. Is there research to kind of support what you're telling us about?
Yeah, there is. As I mentioned earlier, it's an evidence-based health promotion program, and so it was tested through randomized control trials. The original work was done by Dr. Kate Lorig and her colleagues at the Stanford Patient Education Research Center, and they did a randomized control trial with slightly over 1,000 people, again, some in the control group and some in the intervention group, and those improvements I already mentioned, self-rated health status, symptom management, and also reductions in ER visits and physician visits. The other real interesting piece is we talk a lot about increasing your confidence. Well, the higher the increase in confidence or self-efficacy at 6 months, at the 6-month follow-up for these patients, the lower their healthcare utilization was at a year. So we see that when we increase people's confidence, even in the short term, in the long term, we can reach benefits from that. And many of these health benefits and these cost savings held for 6, 12, 24, and even 36 months for some people. So really exciting. I think that the last thing I'll mention about that is that the CDC Arthritis Program actually recently did a meta-analysis, which is sort of a study of the studies, if you will, of the CDSMP. And they ended up selecting around 23 different research articles that had been other implementations of the CDSMP, you know, whether for different target populations or in different settings, et cetera. And the study of the studies actually showed that on many of the same variables that we looked at, we saw small to moderate changes or effects, which, you know, means that there's also a possibility for potentially for a public health intervention for this as well. So it's not that it's just in particular settings, but we're seeing those things hold across settings and across populations.
Now, and in addition to benefits to the participants, are there financial benefits as well?
Yeah, there are. So part of the Stanford study was also to do some cost effectiveness studies to sort of look at, is this going to save money? And so we did see in the studies, the original research studies, cost savings for patients of somewhere between $400 and $500 per patient, and at the same time we saw reductions in hospital inpatient stays, which we all know can be very expensive. And all of these obviously point to the opportunity for potential savings for the CDSMP for patients, but also for systems. So another piece of the work that they did out at Stanford was in looking at a healthcare system, and in this case it was Northern Kaiser Permanente healthcare system. And when they looked at the people who took the program versus the people who did not for that system, they found that for just slightly under 500 patients, the system saved $400,000. So it's easy to see how the benefits for this, the financial benefits can really add up quickly.
Now, Lisa, I understand that the CDSMP also has several associated programs. Can you tell us about the other versions of the program? Yeah,
absolutely, and that's been kind of an interesting thing that's developed as well. So the Chronic Disease Self-Management Program is what we sort of think of as the flagship program. It has, it's for everybody and it catches everybody no matter what type of chronic healthcare condition you have. But there were also several other iterations of the program that have been developed. One that I want to talk about particularly is the Spanish language version of the CDSMP, which is called the Tomando Control de su Salud program, and I'm sorry, my Spanish is not great. And this was actually studied in another way, so it has additional studies with it to provide a cultural translation of the program. So it's not a direct translation from English to Spanish, but rather it was studied to see that the program itself made more sense to people of Spanish language cultures. It still uses all the same core tenets, so it still has self-efficacy, action planning, problem solving, all those same things, but it also has other things that are specific to this target population. In addition to that, and I think they're listed on the screen right there, there's a number of other programs, and I'll just mention one of the more condition-specific programs, and that's the Diabetes Self-Management Program. That's also available in English and Spanish. That program, has about 50 to 60% of the same things that we see in the CDSMP, so those same self-management tools and strategies, those core tenets. But in addition to that, it has some other guidance to help people who are living specifically with diabetes or caring for people with diabetes. So it really provides additional information on things like managing, your blood sugars and, planning meals, planning for sick days, that sort of thing. And all the other disease-specific programs do similar things.
Thank you, Lisa.
Sure.
Well, it certainly sounds like there is a lot of evidence to support using the Chronic Disease Self-Management Program to help engage people more fully in their health care. This might be a great time to hear about the benefits of the program from someone who is taking the workshop. Let's take a look.
Hello, my name is Norma Pettit, and I'm a member of the program Healthy Living. Healthy living, to me, believe in myself. Even when you go to the doctor, you don't tell them everything, and some doctors don't care about whether you bring notes or not. Oh, put them away, they'll say. But when you go to the doctor, you can't remember everything, and you only have a few minutes with them. But then you get back home, and it's like, now I don't know what to do for myself. But by talking to each other, we've maybe had the same experience, so sometimes we get more help from each other. Since I started the Healthy Workshop 6 months ago, I've disciplined myself. I really do my walking. I really do the walking on the stairs. I have a pump bicycle, and I have it right in front of my couch, and I use it several times a day, maybe only a couple minutes, maybe 10 minutes, maybe 20 minutes. But it's there for me when I want it, when I need it. I might sit down for a few minutes and I'm up. I'm always thinking of something to do. And that's probably one of the best things for me. Because if I don't do it, nobody else is there to do it. If I drop something on the floor, if I don't pick it up, there's nobody else behind me to pick it up. I enjoyed it. We looked forward to it. We made sure that, I think everybody that signed up for it was there every meeting. We visit and we joke and we laugh. And laughing is also good medicine. I think the more people that we can get to come to these things, they'll live a better life.
Well, it's easy to see why people like the workshops and the personal benefits, but I'm also wondering if there are benefits to healthcare providers as well. You talked about healthcare or care providers or caretakers, and I'm wondering, do healthcare providers also reap benefits from the program and the workshops as well?
Yeah, absolutely they do. I mean, the first and most obvious one is the potential for cost savings that we've talked about, and so cost savings not just about dollars that healthcare dollars that people spend, but also the resources that are available in healthcare systems and in healthcare provider offices, et cetera. So that's one potential benefit that's pretty obvious. But beyond that, I think the real interesting thing about this is, I work with a lot of healthcare providers in the field, many who I've trained to be leaders or trainers for this program. And what you hear all the time really is that healthcare providers are just as frustrated as patients are when things are not going the way that they should be going. So people get into the healthcare profession because they want to help people to have better clinical outcomes or better health outcomes. They don't get into the system necessarily to have to worry about all these other the business aspects of this. So I think that, what I learned from that is that, there's an opportunity and potentially a benefit for healthcare providers to build better interactions with their patients, which hopefully leads to better health outcomes, for everybody. I think that, a good example of this is what we see in the chronic care model, which is a kind of a roadmap, if you will, for effective management of chronic health conditions. So remember we said earlier that acute conditions is sort of what our system is set up for. Well, the chronic care model actually helps us to look at this system together, all right, where it's not just about what patients do and it's not just about what the system can do, but it's how those things interact to create these good interactions between patients and and their providers.
Well, tell us a little bit more. How exactly does it work?
Sure. So I think there's like a graphic up there that gives you sort of, this is the graphic representation of the chronic care model on your screen. And what you can see is that the overall goals, of course, which is at the bottom there, are improved outcomes. It doesn't say improved outcomes just for patients, but it's just improved outcomes, right? So everybody wants to benefit. The key to this are these productive interactions between providers and patients or providers in their system, all right? So productive interactions, not just good communication, but actually interactions that are helping to improve these outcomes. You also see, and I don't know if there's maybe they can circle that, but there's a bullet there on self-management support. So we have, the healthcare system side, we have the community healthcare side, and then we have within the community healthcare side self-management support. Self-management support is what activates patients to get engaged in this interaction and take advantage of both community resources, but also to work better with the healthcare system. So the CDSMP, which is a self-management program, obviously is a really good fit. It fits into that niche really well because it's a community-based program. The intervention meets people where they live and where they live with their chronic health care conditions, and where they manage that 95% of self-care. And so hopefully, what we see from all of this improved interaction is that we have patients who are more informed and more activated, better able to influence their own health outcomes, and better able to engage in these productive interactions with their healthcare systems, and hopefully healthcare systems that really feel that they can meet the needs of their patients as well.
Well, Lisa, take us through that. What do informed and activated patients do?
Yeah, well, they do lots, actually. So informed and activated patients are people who are engaged in their healthcare, so they're people who both seek knowledge about their condition, but also seek to make changes in their behavior that will help them to have better health outcomes and have better personal wellness. So there's again, another graphic up here that describes something called the patient activation measure. This is a measure that kind of sets people on a continuum, from 1 to 4, with 1 being sort of the least active, although not active at all, and 4 being folks who are really active in their engagement around their healthcare condition. So, obviously we like to see everybody be a 4, but not everybody's there. And so it's important to remember, though, that at every level, even if you're, in that level 4 where you're maintaining largely your health behavior changes, et cetera, even folks in that level can still benefit from self-management education, because if an adverse event happens, or, if something, some crisis happens and they falter, they now may be sort of set back or relapse a little bit in terms of, their level of activation, maybe get a little disillusioned that the things they were doing didn't make a difference, et cetera. So there's an opportunity always for us to be moving people along this scale, and seeing if we can get patients who are more activated. Now, here in New York State, we actually did some interesting work with the patient activation measure. We surveyed about 500 people who were folks who were coming to our chronic disease self-management programs, and we took a look at where they were at baseline on this scale, and we saw that about 65%, so 2/3 of the people who were coming to these programs, were in the stage 1, 2, or 3, so who really had a significant opportunity to potentially progress along this scale, and hopefully could really take great advantage of the self-management education through the CDSMP. Now, we don't know yet, because we don't have all the data in, whether or not it moved people on that scale. But we're sort of, speculating that that's what happens. That people who engage in a program like the CDSMP will become more activated patients and will move a little bit on that scale, because they'll now have some of these tools and strategies that they need to be successful and to build confidence. And we're hoping, that when we have all the data, that's exactly what it's going to show. And in addition to that, we collected a lot of other data, so the measure actually can also help us to understand not just who took the program, but who benefited the most from the program. Because when we kind of couple that up with all the other information we have, like health outcomes information and completer ratios, et cetera, we can find out who the program actually is the best fit for, which also helps us to understand who it's maybe not the right fit for, the CDSMP, and then what do we need to do to get folks ready to really take advantage of self-management education.
Well, my understanding is that there are other, chronic disease self-management programs out there. Why would healthcare providers choose the chronic disease self-management program, over others?
Right. Well, hopefully they just take my word for it. But if they won't, don't take my word for it, because, one of the reasons you would pick this over some of the other programs is really because it has been around so long, because it has been tested in so many ways with so many populations, and in so many different settings, and we know that it works. It works in community-based settings, it works in clinical settings, it works for old people, it works for younger people. We know that it works for everybody. We've got all this evidence that shows that people can make these changes, and that these changes stick. They stick for 6 months, 12 months, 18 months, 24 months, and even 36 months in some cases. So why not choose the CDSMP? I think one of the other reasons is that there has been a tremendous amount of effort in the last couple of years to disseminate this program really widely. And so the federal government, through some of the American Reinvestment and Recovery Act funds, provided funding to the U.S. Administration on Aging, who then disseminated that throughout 45 states and 2 territories to actually build an infrastructure to deliver this program. So while some of us were working on this, this really allowed us an opportunity to ramp up the effort, to the point where now we have a lot of New York State covered, and this program can be available to people everywhere. So if you're a clinical provider and you're trying to figure out, well, how can I get somebody self-management education, it might be just as close as the next community center or the somebody right outside your door. So in addition to the great evidence, we also know that it's really readily available in most places, and it's also a really low-cost model. It relies largely on peers who are volunteers, and so while staff resources are used typically as trainers, peers who are volunteers deliver the program, and by doing that we can keep the cost of the program down so that it's something that can become a part of regular clinical care without increasing the burden of the cost of the program. So there's lots of really good reasons to choose this program.
So cost benefits, evidence, access, research, deliverables, outcomes, you certainly have made a solid case. I think this would be a great time to hear from Bonnie, a nurse and health educator who has been working with the chronic disease self-management program for several years. Let's take a look.
Probably learning about self-evidence-based programs did change how I do look at educating people in the community, rather than just standing and giving out the facts, that you have them work with goals and action plans and problem solving and brainstorming. And by individuals working through those methods, it does put them in the mode of thinking about their own care and self-management and putting them more in the driver's seat for it instead of just rote learning. Project Healthy Life is important because it is evidence-based, but it's also important because it includes everyone with chronic disease, whether you have diabetes, heart disease, lung disease, arthritis. All those people have the same concerns, the same fears, the same problems. So when you put them all in a room together and have the class, they interact together and can help each other. The very first course that we taught in Cape May County was to a senior complex, and we had about 15 people in the class. And they went through the class doing very well, doing all of the activities, the action plans, the brainstorming. And when we got to the very last class, a man who had come to the first 5 classes in a motorized scooter came on a walker. A lady who had always come to class with oxygen that she used 24 hours a day, 7 days a week, came without her oxygen, which really scared me. And then a man whose blood sugars had run constantly for several years in the 300s had, he said, for the last 3 weeks of the course, nothing over 115, which was really good for somebody who has diabetes. I really do believe that these things were able to happen to these 3 people because of taking the 6-week Project Healthy Life course.
Now, Lisa, you were here to talk about chronic disease self-management programs in New York State several years ago. I recall that when things were just getting started at that time. I understand that in just the past 2 years, as part of the national effort to build infrastructure to deliver chronic disease self-management program, your center, partnering with the New York State Office for Aging and Department of Health, have expanded access to the program, to much of the state through some of the innovative partnerships that we referred to early in the program. Can you describe how that's been done?
Yeah, that was a big effort. So we are one of the ERA states. New York State did receive funding from the ERA initiative through the U.S. Administration on Aging. But I do want to say that we do have a really long history with the CDSMP here in New York State. So while those funds helped us to be able to expand the work that we were doing, a lot of this work was being done already, and it really provided a lot of opportunity to link that together. And I'll talk more about that in just a minute. The focus here in New York State was largely on working with older adults with multiple chronic conditions. So even though many of our partners serve many other people, and that was absolutely perfectly fine throughout this, our focus was really to work with older adults with multiple chronic conditions, largely because of the things that we mentioned earlier, but I think there's also some other data we can kind of talk about related to that. Now, some of our decisions around that were driven a little bit by the funding, because the funding came from the Administration on Aging, so obviously, and through our partnerships. But at the same time, we have to recognize that folks who are older, who have multiple chronic conditions, are actually impacting the healthcare system and are actually experiencing a lot of adverse effects from having these and not maybe having the good care that they need, and self-management can really help with that. Also, I think there's a graphic up about Medicare spending. So Medicare is the public funding that funds health care for people over the age of 65 and also for people with disabilities. And when we really look at that, and this graphic represents that, we see that the spending for people with chronic conditions is higher. All right, the higher the number of chronic conditions. All right, so where people with 5 or more chronic conditions are using, I think it's around 59% of the healthcare resources in Medicare. So we wanted to disseminate the program in a way that we could reach targets who could potentially both, 1, really benefit health-wise from the program, 2, hopefully maybe slow their progress on the progressiveness of some of their chronic conditions, but 3, could also potentially represent a cost savings or a cost avoidance for Medicare and or other healthcare systems. So there's a lot of thought that sort of went into that and why we would do it that way. Now, the way that we did it, here in New York State, we actually broke the state into 6 regions. So the regions are not sort of equal geographically, because we have really some regions that have only a few counties and some that have up to 17. But what we tried to do was, by looking at that population, say to ourselves, within these regions, who are the people that are, at risk, the people who have more, are 60 plus and have more than one chronic condition. And so we tried to break it up population-wise, so that there was an opportunity for each of the regions to reach similar numbers of people. Now, as I said, we have had a really long history with the CDSMP here in New York State. And so we also worked really hard to link in organizations that were already delivering the CDSMP, because there have been many organizations who have been delivering this apart from, any effort that the state has made. And so we really wanted to find those folks, and we wanted to link them into this state effort, so that together, we could work to more broadly disseminate the program. We could link those partners with our new regional partners to build capacity quickly in an area, so that the program became much more accessible much more quickly. And we did all of that, recognizing that we had to be really pay really close attention to the quality assurance and the quality improvement efforts of the program, because we know that if we're ever thinking that people are going to fund these programs, we have to be sure that we're delivering them the way that they were intended to be delivered, and that that's consistent, so that if you go into a program in Broome County, and you walk into a program in New York City, or you walk into a program in St. Lawrence County, it's the same program.
But that must have been incredibly challenging, because the state is so diverse, geographically, but you've got suburbs and rural communities and urban communities, and large and small, and how did you go about zeroing in and kind of tailoring the program for those various diverse
well, that wasn't easy. So that's a big question. That wasn't really that easy, but it was something that we really, did achieve. What we did was we named like a regional lead. So in all of our regions, we worked with one particular partner who would sort of serve as the representative for that region, to help disseminate information, to help to get training capacity built, and to link in partners. Now, that's easy in some of the regions that are pretty small, but in, say, the Western New York region, which is around 17 counties, that's a little more challenging. So then what it really became about was really about linking those partnerships together again. How do we find folks who are doing this, or who are interested, and can we bring them to a central location, and can we make them work well together, or help them to work well together? A lot of that we actually did with technology. Remember, I mentioned earlier technology. And so we used an online learning community. So we developed this learning community as a way to disseminate information. It helped people with logistical support. So if they needed help with licensure, they needed help with bulk purchasing, they needed information about recruitment or training or quality assurance, whatever the case. And we used this online learning community to run monthly webinars. We used it to disseminate information. We have forums on it and blogs. There's a shared calendar, so you could find out where there was training near your location. And we also have like a shared learning tool file cabinet. So all these kinds of things that not just we developed at the QTech, but that were developed by many of our partners are housed there. So as a member of the online learning community, you can get access to all these things very quickly and very easily, which really helped to be able to disseminate more broadly.
Exciting.
Yeah, it was really
great.
It was a lot of fun, and I like technology, so I was really happy to see that be a good vehicle to really do this. And as you said, New York State is a big state. So in any case, we also collected a lot of data on all of the work that we did. So we learned a lot about our partners. We learned a lot about the programs and the delivery sites. We learned a lot about the participants and how satisfied they were with the program. We worked a lot with leaders to understand, their delivery and how they were doing with that, and to support them, in their ongoing development as leaders of the program. And we collected a lot of data related to the outcomes for patients as well, as well as some of the other things we mentioned, the patient activation measure, et cetera. So, hopefully, all this data kind of comes together to tell the story of not just what we did, but what we achieved. I think will also tell us what we didn't achieve and what we need to do next. I can't talk to all that right now because we don't have all the data, but I'll just give a little plug for the fact that in May of this year, May 7th and 8th, we are going to be holding a summit on the Chronic Disease Self-Management Program, where we're going to disseminate all the information about the program, and we're going to bring multiple partners together to actually actually start working on sustainability plans for the program in all the different regions here in New York State. So, if you're interested in that and you're in New York State, please stay tuned and, and tune in for that. I think that, all of this presented a great opportunity to disseminate the program, and maybe we want to talk, I know we have some maps, so maybe I'll show people a little bit about what we did by looking at the maps. So the first map we have, and hopefully you can see that on your screen, we can see the outline of the 6 regions. So each of the regions is kind of outlined with black. And so within that, hopefully you can find your county and you can see which region you're in. And that will help you, again, if you go to the website and you're interested in learning about your region, you can find out who your regional contact is, et cetera. So if you want to learn more about things that way. So that's one thing to look at. The next map I want to have put up, so now you see there's all these shaded gray areas on the map. Well, the shaded gray areas represent counties that have the capacity to deliver the program. So by capacity, what we mean is that we have trained master trainers or trained leaders in those communities who are ready to deliver the program. So either they are delivering the program on their own, or they are potentially available to train people in your organization to deliver the program for you. So roughly 50% of the state, maybe even a little bit more. More than 50% of the population of the state has capacity or has access to the program because a lot of our population center is downstate, and we have a lot of really robust programs in the New York City area. But we also, you can see from the map, even as far north as St. Lawrence County and as far west as Erie and Chautauqua, I mean, there's all kinds of capacity around the state for CDSMP. Now, the next map is going to put some hash marks on there, and what that will tell you is that in those counties, we also have access to some of the additional programs. So the things I mentioned earlier, the Tomondo program, the diabetes self-management program, the positive self-management program, et cetera. So those are all accessible in those places as well. And of course, we can still bring the other programs to the other counties, but this is where we have the capacity currently built from this two-year project. The last map I'm going to show is really just to show you where we've delivered programs. And so, we have, obviously a lot of concentration of programs in the downstate area where we have a lot of population, but we've actually spread the program across the state fairly well. And, the different colored dots sort of represent the different programs. Most of the work's been done in CDSMP, but we've had a fair amount of work in the Spanish language versions of the program and the diabetes self-management program as well. So, it's been a long road, but, and this is not something we did. This is only something that we could have achieved really through all these really innovative partnerships, with public health agencies, with area agencies on aging, with federally qualified health centers, with, senior centers, community networks and community care networks, just anybody and everybody, faith-based organizations, anybody who would hear us, we brought the program to. So, it's been a tremendous effort by everyone in the state, and, and there's still work to do, as you see from the map, but at least, we feel that we really made a really good start on trying to reach people everywhere in the state.
Well, let's talk about those people.
Okay.
Sure. What can you tell us about the people that you've reached through this particular effort, Lisa?
Yeah, well, we reached a lot of people, although I will say we didn't really even scratch the surface of the numbers of people who could benefit from the program. But in New York State, in about 18 months, because it's been a 2-year project, but it took us a while to get ramped up, but in about 18 months, we reached close to 4,700 people, which is not a small amount, but not near what we could do if we could really move the program a little bit more. That happened in about 400 workshops, just a little less than 400 workshops. And we reached people from ages 18 to age 100. So, even though our target was largely older adults, and you can see that the mean age we had was just slightly under 70. So obviously we reached mostly older adults, but in addition to that, we really did reach people across the board age-wise. We also reached people who did not report having really good health. So remember we talked about the patient activation measure earlier. Typically people who are more activated perceive themselves as having a better health status. Not always, but often. But we reached 25% of the people we reached really didn't feel that they had good health or felt they had poor health, which also presents to us, some information about, that we've reached beyond sort of what we call the low-hanging fruit, or the people who normally join these programs, and we've found people who really have an opportunity to engage in their own self-management, maybe in a different way than they ever have before. So, and because we know the CDSMP typically moves health status for people, we're really excited to be able to look at our data and find out what happens with that. In addition to that, we reached a very diverse group of New Yorkers, and I think there's a pie chart for that. So people of all races and ethnicities. We delivered a lot of programs in other languages other than Spanish. We did a lot of work with Russian programs, Chinese programs, Korean programs, Japanese. So we had a lot of opportunity to reach a very diverse group of people in New York. I don't have a chart for this, but we did reach both men and women. We reached more women than men, which is pretty typical because women, I think 2 reasons. 1, women typically are the joiners of these types of groups. But 2, I think that, women also are living longer, and so when we see that our age range is on the higher end, it's likely that there are more women to access. But I think that also says that we need to do more work to reach men. And so I don't want to downplay that like good for us. I think we really need to reach more men. And so we also, reached, men and women, but with some opportunities. And we reached folks with multiple chronic conditions, which was our other target. We really wanted to meet folks who had 1 or more chronic conditions. And, again, I think there's a chart for this. But if you look at the overall effort, what we really, here's sort of by region, and you can look where you are if you're interested in your region. But if I'll, draw your attention to the focus of the New York State total. And the New York State total, about 50% of the people that we reached had 2 or more chronic conditions. So we definitely, found the people that we wanted to get into the program who could potentially benefit from it. Not that everybody couldn't, but, in terms of our own target. So I think overall we reached our targets. But we also developed really great partnerships that I think will be long-lasting and that can help us to reach out to many more people than we've had the opportunity to reach so far. So, so good job, but there's a lot more work to do.
Well, you've made significant inroads. We have some questions that have come in for you, and let's get to those right away. This has come from the University of Connecticut. How can I support this kind of program in a specific chronic disease with a small underserved population with unique needs? Are there funding sources to demonstrate the feasibility and efficacy of this program in this small population?
Mm-hmm. Well, in terms of funding for the program and in terms of the long term, we're certainly looking at and is being looked at the national level where there's potential long-term funding for programs. In the short term, what I would suggest is that, what you really need to do is identify kind of the target population. There's a lot of work actually going on in Connecticut because I've done some work with the folks there. So there are CDSMP programs in Connecticut. So, one thing would be to link up with those programs and find out, if there's a way for those folks to help you to deliver the program and build some capacity. And I would also say if it's a particular target population that's, underserved, certainly if this is a university-based question, there's an opportunity potentially for some research money, to look at these kinds of things, et cetera. And so, I'd be happy to kind of talk with that person, more at length about some of those things and to connect them with the people in Connecticut that are doing the program if they're interested.
And is there a website or contact information for you or a telephone number for our viewers?
Yeah, there's a slide, and I don't know when they're going to put it up, but I'll read it to you now because, of course, I don't.
Oh, no, I'm sure they have it.
Okay, they have it. Okay. All right. So anyway. Yeah, well, that's the helpful resources. But there's some other helpful resources on your screen right now. So the first one is the Stanford Patient Education Research Center. So you can certainly contact them as well. But in addition, here's our contact information here. We have an 800 number you can call us at. We also have an email that's easily accessible, and we have staff there who can, connect you directly with me if your questions are more specific to some of these efforts, or if you just want to learn more about the program in your area, you can do that.
Okay, let's return to some of the questions that have come in. Has cancer or cancer screening ever been included in this program to reduce risk factors for cancer or to increase cancer screening?
Mm-hmm. So certainly any screening of any type is something that we would hope when people are good self-managers and are activated patients that they're engaging in those kinds of behaviors. We don't add things to the program, so we don't do we wouldn't add in any type of screening to the program because the program itself, again, because it's evidence-based, exists kind of on its own. But that said, we've had many cancer patients in our programs, so there's certainly. Again, there's a lot more information about that out there, but it certainly is a good fit for that, yes.
And how do you go about attracting and retaining participants?
Yeah. I think the most important piece of recruitment is really helping people to understand what the program really is and what it really isn't. And remember, we talked earlier, it really isn't patient health education. So if somebody thinks they're going to come in and sit and bring their pill bottles and get a medical or medication reconciliation or listen to someone give them advice, that's not what happens. So we actually developed what we call here in New York our version of a session zero, which is a recruitment strategy to help people to understand what the program is, to get them to see how interactive it is, and to use that as a way to recruit people into the program. So that's available on our website.
Okay. Are there consistent lay leaders? Do you pay lay leaders, or are they volunteers?
We have had both models. We have lay leaders who in some places are paid a stipend of some sort. We also have many, many volunteer lay leaders. And usually it's the role of the master trainer, who trains lay leaders for an organization to try to mentor those people. We do have dropout rates of lay leaders. So, lay leaders are people who have chronic conditions. So sometimes they have to take care of their own health, and that means they can't lead programs. But largely the retention rate is, somewhere around 70% or so.
Do you use community health workers?
We are starting to get into a lot more use of community health workers here in New York now that we're doing more partnership with federally qualified health centers. And community health workers are actually, again, great folks to be lay leaders for this program.
When we looked at the map of New York State, the map shows that the workshops, someone indicates it doesn't show that the program exists in their area. Does this mean that a participant or a provider even could not participate if it's not specifically in their area?
No, absolutely not. Again, this is what we've been able to develop so far, and in fact, this last couple of months of the training we have, the grant, we've been doing a tremendous amount of training to try and expand our reach. The Quality and Technical Assistance Center, hopefully is here to stay. So if you're interested in training, you can contact us, and we can, partner with you to figure out, how do we get the program into your community.
Okay, that's exciting. You described how healthcare providers can benefit from their patients participating in the CDSMP. Can you give some examples, Lisa, of how a provider might recommend the program to patients?
I mentioned technology earlier, so an electronic health record is potentially a way that, this can be built into that for anybody who might have a chronic health condition, that people could be referred to or recommended to this as a community resource. I think beyond that, though, one of the things that's happening, right now that represents a real opportunity are things like the medical homes and the patient-centered medical homes. We've done some work with some patient-centered medical homes, trained some of the staff, and that helps to link kind of the clinical piece, back to this kind of ongoing care piece. We're also seeing out in Western New York, there's a whole effort to bring the CDSMP to physician practices. Some of that's just making physicians aware of the fact that these things are happening in their community, but it also is about working with them to understand how can they most quickly and easily recommend the program to people. One thing I will say about that, though, is we all want to link doctors into this and other healthcare providers, but we've got to make sure we have programs readily available and happening ongoing, because that's one of the challenges of these things, is to keep the program available for the people who really need it.
Well, Lisa, this has been an extraordinary program. You've provided wonderful information. You and Philip McKellen are doing a terrific job. You've certainly provided us with great contact information, background information, evidence that this is a program that works, and your passion is infectious. And so we appreciate you being here today.
Sure. Well, thank you very much. It was a real pleasure to be here.
Thank you so much, Lisa. And thank you very much for joining us today. Please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. An archive of this webcast will be on our website within 2 weeks. To obtain nurse continuing education hours, CME, and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. Please join us on March 15th for the next broadcast of Public Health Live on teen pregnancy prevention, lessons learned from New York State. I'm Joyelle Ray-Alexander. Thanks for joining us on Public Health Live. Thank you so much, Lisa.
So much.
You're
really
great.
Thanks.